All right, so thank you everyone for joining today. Welcome to the Society of Thoracic Surgeons General Thoracic Surgery Database Quality Improvement Series, Reducing Readmission Rates. Today is Thursday, May the 29th, 2025. So thanks everyone for joining today. On the call with me today from the STS side, we have myself and Carol Crone, Emily Conrad, Nancy Honeycutt, and our GTSD consultant, Ruth Raleigh. And we also have our special guest speaker, Kelly Rubino. So I'll introduce Kelly here just shortly. So thanks everyone for joining today. For those of you who have not been on our quality improvement series calls yet, I just wanted super briefly before I turn things over to Kelly, just to remind everyone of the goals of our quality improvement series. And just I'll just touch briefly, go over the goals here. It's one, to show value of the database outside of just getting reports and those quality ratings. Also, the goal is to show how important you are as a data manager in abstracting the data. We're going to make our STS data actionable. We're going to also help work to decrease the cost for your institutions. Reducing those readmission rates obviously helps to decrease the cost. Then also we all want to be part of a national team effort. So we hope you guys are joining us in the quality improvement series and working to reduce those readmission rates at your institutions. And also, most importantly, because it is awesome to work together, awesome to work towards something together. So hopefully, we all can continue to work on this goal of reducing these readmission rates and making our data actionable and things better for your institution and for leadership as well. So with that being said, I'm going to go ahead and turn things over, which I could get on camera. I said I was going to do that. Sorry, Kelly. So I just wanted to take a moment to introduce Kelly Rubino. She's the Clinical Data and Quality Manager at Hackensack Meridian Health. And Kelly so graciously volunteered to present today for us on today's Quality Improvement Series. So I'm going to go ahead and turn things over to you, Kelly. I'm going to stop share so you can share your screen. And there you go. You should be able to. Perfect.
And now, as long as you can hear me. Good afternoon, everyone. Thank you, Leanne and STS, for this opportunity. It is a truly humbling experience to be able to share with you what we have been doing here for the past 10 plus years at Jersey Shore University Medical Center and Hackensack Meridian in our southern region. So my presentation isn't going to focus strictly on readmissions, rather than everything that we do here on a monthly basis, looking for opportunities to affect change. So the data that I'm going to present is our actual data. This is the actual presentation that I presented just this past Tuesday at our practice meeting. We have a practice meeting every month. Our our participant consists of 5 hospitals and 4 surgeons. So those 4 surgeons operate across those 5 hospitals under one participant ID. A little background about myself. By clinical background, I'm a thoracic cardiac surgery intensive care unit nurse. I have overseen the thoracic database. I actually started it back in 2015, left it for a little while, and then came back. I also oversee our other databases here and for the Department of Surgery at Jersey Shore, NSQIP, bariatric and pediatric NSQIP, for those who are familiar with those. So to go ahead and get started.
Oh, Kelly, you accidentally got muted there.
Thank you, Carol. Better?
You're welcome. Yep.
Sorry about that. I was probably clicking on the wrong screen. So one of the things I first share with all the surgeons and the PAs, and we have our lung screening, our navigators, and our practice managers on this call, is just some reminders. I frequently get calls asking me, how old can the PFT be, or how long can the labs be? So this is just their gentle reminder every single month. I've also added in the thoracic risk calculator with a hyperlink to it for them. We are in the process of moving vendors, so I just keep them updated on that. And then we have some other reminders that I give them that are just more specific to us and outside of STS. We continue to strive to create templates in our Epic system. So one of our surgeons and PAs is working on that. And the reminder to document the removal of our chest tube so that our data abstractor has that information for when we are doing our abstractions at the end of the month. I also share current clinical trials, so I get this updated usually about quarterly. This is just a reminder for everyone on our call for our practice meeting of all of the clinical trials are out there, so that we don't forget to make sure we're accruing our patients onto trials that are available. We discuss all of our future and in progress projects. So these are some of the ones we're currently working on right now, whether they're research or QI based or PI based projects, and then any recent publications we share with the whole team that, just so everybody's aware of all the happenings that are going on within our thoracic surgery practice. I give them updates on the STS every month. So, coming up soon is an abstracts are due. So I'm looking to see if any of them want to put in any abstracts with me, and hopefully we can get with him. That is my plan. I have a few days left to get that done. And then I go into our National Quality Improvement Project. So I keep them updated every month on when the webinars are. I do put them on their calendars every month, so if they want to join in and listen as well. And then I had created when the STS first, I think it was probably back in October-ish of 24, that the STS started doing these webinars and gave us this information. So I decided I would start to track it on a monthly basis. So I created this dashboard where we're looking at our yearly and then looking at our rolling 12-month to see where we're lying as far as being able to meet the benchmark that STS has. And I did just update this benchmark at 6.94%, which was on our most recent report that I came out. So it's just a way for us to track it every month. And what we will do, so now I'll show this a little bit later in the presentation, but anytime there is a readmission, we talk about that readmission as a group. But I bring that later on the slides when we go through all of our post-op events that we have. We also keep a tracking of our discharge to home. I'm sure many of you out there are aware US News World Report looks at lung cancer surgery specific and discharge to home. We do not specifically pull out just Medicare patients. We look at all of our patients. But we do specifically pull this once a subset out of the lung cancer surgery ones, just so we can keep an eye on which patients, how we're doing as far as our patients going home. Happy to say we're, doing very well there. But in addition to that, we actually track all of our patients. So we're always looking for reasons why patients aren't going home. So this is just a copy of one of the tabs in my spreadsheet that where I look to track. So if anybody's asking why are our patients not going home, and we can look to see real quick, what procedures they were, if there was a specific age category. So it's just a quick way of tracking and knowing who these patients are, so we can look for opportunities to maybe make an impact to have our patients going home. And then I usually then go into our monthly dashboard review. And this is where we first start to just look at volume. As all of us data managers know, our surgeons are always interested in what their volume is. So we always keep track of what their volume is and giving them their most recent updates. And I apologize, there's something with this slide because these are not zeros. I swear to you, my surgeons have been operating all year long. I'm not sure why these zeros transferred over, so I might have to update the slide deck. Not sure what happened there. We also then look at our month-to-month comparison. So you can see where all the 25s are in here. So we look to year over year and then by the month of the comparison of where things lie as far as volume. We look at our growth by year. So, and we project out how we think we're going to go. Nice to say we have this nice climb going up over here. And then specifically also, again, looking at a robotic procedure log. So we pull these in specifically looking just at each surgeon, their volume at each hospital, and then by procedure of our volumes there. And then also annualizing that out by the year, looking at our growth and how we're doing. These are our outcomes. So I just want to stress here for our outcomes, So for those data managers that have been around back in the day when we had minor and major procedures, when we switched out to doing the 5 major categories, we dropped putting in all of the minor procedures. So we only put our major procedures into the STS database, but we wanted to have an ability to capture all of our complications to know how we're doing, even though we weren't putting them to STS. So I'm fortunate enough that I have many different resources in order to grab all of our, cast my net very wide as far as complications and outcomes. So I use our internal reporting structure. It's called the BI report system that we have. We're actually moving over to Google's Looker platform, and also Vizient. So I use a combination of those with our STS reports in order to populate this database, looking at our length of stay index, our mean observed length of stay days, mortality index. And then we look how many cases we had with a post-op event. Again, that discharge to home, we're always looking at our discharge to home. This is overall what we have, our mortalities, and again, listing out our readmissions. And then this would be any readmissions, so not just the lung cancer ones where I showed on the previous screen. And then we're always notating, if a patient didn't go home. In this case, there was one patient that didn't, what type of the case was, and what was the general reason for it. So when I talked about earlier, I said we go into depth on what the post-op readmission was. So this was the case where we go into all of our post-op complications as well as readmissions. This is a running log, and I'll show you what it kind of looks like later on in the presentation. So all the surgeons, the PAs, and the rest of the team on the call every month, we would sit and look, okay, this wedge patient, it's an STS, it was a lung cancer case, what was our event? They had a post-op air leak, and they also had a readmission, and then just a little a kind of summary of what the events were, so that we then talk about it, and the surgeons usually to each other would then talk about maybe ways of how could we have avoided that or not avoided that. And in this situation, the readmission we couldn't have avoided. I also do this is sort of like my projection. So looking to see what our ratings are going to be. I keep a rolling annual and then a rolling 12-month here. And then I kind of project what I think our rating is going to be. And I usually get pretty close to it. The other thing that we monitor here is our COC standards. So I don't know those of you who do monitor that. We look at the standard 5.8 for the Cancer on Commission, making sure that we are appropriately getting the lymph nodes needed to make sure that we are compliant with that standard. And that's just kind of the major complications down here that we get rated for our risk adjusted report. So this is more like just a way of just monitoring how we're doing in between the times that the risk adjusted report comes out. And then when it's available, so in this particular case last Tuesday, we did have our most recent harvest report came out. So I would always present that at our practice meeting every month. First off, always usually going with the summary of how many participants there were in that particular harvest, and then where everybody stood as far as the number of worse than expected, expected, or better than expected. And this is our actual report I'll share with you. And this is how I shared it with our surgeons. And then when needed to, we'll do a deep dive into things. Usually here we're looking to see, how close or how far away are we getting, so that, looking to get that as expected to the exemplary category is what we're always striving for. Same thing for our esophagectomy, again, just we didn't meet the minimum criteria here, but just looking to see where we stand. And then I also do share with them the comparisons with the STS and the NIS database, our discharge mortality, the lung cancer, usually the minimally invasive for stage 1 lung cancer. And then just again, how far or how far to the left or to the right we are getting to be able to provide any area of looking for opportunity. And then this one is the length of stay, which we have usually, I think probably for the most of our program, have always stayed below STS and the national inpatient sampling as far as length of stay. So to circle back for the purpose of the STS quality improvement, This is a screenshot from, I believe it was back in October. Leanne and Ruth had presented some of the participants, everybody's numbers. I kind of did a dive onto where I thought we lie. We lie somewhere in this yellow area. So I knew we were above, the average rate that STS had. And also here is the length of stay with the readmission rate. Again, we lie somewhere in this yellow. I don't know exactly what our number was. So I shared all of this information when it was presented at this forum back in October. And then we were able to look back real quick. And like I said, we have this dashboard tracking. So, why the one surgeon said, I don't think our readmissions are that high. And I said, no, they were back then. And, I was able to quickly pull out who was our readmissions. I can quickly pull out who are my STS cases, who are my cancer cases, and then be able to look real quick, who are those readmissions? Why are they being readmitted? So I can look back historically, or like I said, every single month, we look at any patient that had a readmission as well as any type of complication. It's just tracked and reviewed every single month. So we know, there's no surprises when the risk adjusted report comes out. And there's no surprises when I show the outcomes of where we stand every single month. And then looking at this new page on the STS website, the community page, you can kind of show where we did make an impact because we are down to 5.61% looking at this page. And you can see a nice decrease in the return to the OR as well as our air leak, which we did attribute a lot of our readmissions a couple of years ago were to air leaks. And you can tell from here, there's been no effect on our length of stay at all with decreasing the readmission rate. And that is all for my presentation. Happy to take questions.
Awesome. Thank you so much, Kelly. I appreciate it very much. Yes, thank you. Let's see here. I'm going to go back and share. So yes, if you have questions for Kelly, please put those into the Q&A. We would love to get your questions and continue the conversation. Let's see, we have one question. Can you discuss how you get the COC data from STS?
With my vendor, I'm able to make ad hoc reports. I don't know if you are, but we made a report where we brought in all of the lymph node sampling stations.
Mm-hmm.
And then the data abstractor at the end of the month looks through that and looks to make sure that we have the correct number.
Awesome. Excellent. Thank you. Let's see here. There is, so what do you attribute your short length of stay to? Do you use post-op opioids? It's a question from Catherine.
We've always had I would just say one of the first shocks I had as a database manager and being a previous cardiac surgery ICU nurse is that our surgeon will send patients home with chest tubes. And it was like within the first year, I think, of him being here, and I was shocked that patients go home with chest tubes. So our length of stay, I would say, I couldn't say it has anything to do with opioids at all. I don't know if Dr. Bauer, if still on the call, could chime in and answer to that.
Let me see.
I don't know if there's any specific.
Let's see. Let's see. I was trying to see if he's on, if he could just raise his hand and then I could.
He is on, it appears.
He's
Let me
on.
see if I can unmute him.
Okay.
I don't, doesn't seem like I can unmute him, but he is here.
Oh, there he is. Oh, hold on. There is Dr. Bauer. That's it. There you go, Dr. Bauer. Thank you.
You able to hear me?
Yes, sir.
Okay,
You just went out on us.
I'm sorry, it got cut off. Are you able to hear me?
Yes, sir.
So first, I just want to thank Kelly for all her work. And as she mentioned, 10 years ago was when I was able to recruit Kelly from the CVICU to help build what we did. And as she'll attest with a smile, over that last 10 years, we've met weekly or more than, and it has been daily at the beginning and then weekly, and now it's still weekly and monthly to go over our data. I'd say one super important thing that I would state to all of the people on the call is the importance of what you do. And from the beginning, Kelly and I had an agreement that she would stand up for herself and the data, and that we had to promise 100% of the data was going in. I would push back and question her on things, and she would hold her ground when she felt that what she was entering was correct. And that enabled us to have the highest fidelity of our data at our first audit. And so I commend all of you on your data integrity and what you do. I would also, in terms of the length of stay, most of the vast majority of our patients don't go home with a chest tube. Some do. What we do, though, is I think it begins in the office. So we give our patients information packets. All of the surgeons basically tell the patients that they should plan on going home post-op day one. And it may, in fact, be under 24 hours that they're actually in the hospital. So we set that expectation at the beginning. They all get intercostal, or almost all get intercostal nerve blocks with Exparel. They go home with our narcotic script. One of our projects is going to be looking at how many they actually take, because when the patients come back and see us, most of them haven't really taken any, and if they have, they've only taken a few Percocet. So it's a series of setting expectations, good intra-op pain blocks, early mobilization. Our patients don't get Foleys at the time of surgery. They typically don't get any post-op labs. Our nurses do a great job getting them out of bed. If it's a morning case, they may very well be out of bed in the afternoon, if not certainly the next morning, and they're ambulating. So it's and we're covering 5 hospitals. So it's the 4 surgeons working with the nursing units that our patients tend to go to. Kelly helped me develop protocols early on that all of us follow. And so it's a disciplinary approach with the surgeons, our PAs, and our nurses. The other thing I would say is that when I became chair of surgery, the thoracic division had the most robust quality data. And so Kelly has helped me, now that I'm chair, take what we do for thoracic and we do it across our department with surgeon scorecards, et cetera. So the more things that you can measure and provide feedback and be open and honest. And so we discuss our readmissions, any of our morbidities, any of our mortalities, so we can understand why it happened and what we can do to prevent it. And that is all because of the work that Kelly and all of you do. So thank you to all of you.
Thank you, Dr. Bauer. Yeah, I didn't mean to say that all of our patients go home with chest tubes. That's not what I meant.
No, but
That's rare.
I'm just saying.
But yeah, thank you. Thank you, Dr. Bauer. So we do have some questions coming in. Actually, we have one for you, Dr. Bauer. Do you use IV Tylenol post-op or Lyrica, or I'm not clinical, so I'm going to
So typically, not Lyrica, a lot of our patients will get IV Tylenol in the OR and will do the Exparel blocks. And that combination seems to work very well.
Okay, excellent. Natalie had a question. Do you count the air leak over 5 days of patients sent home with the chest tube?
Yes. But we typically sometimes, so if that patient goes home on post-op day 2, Dr. Bauer will sometimes bring that patient back into the office on day 3 or 4. And if it's resolved and they document the chest tube is out, then no, I don't count it. Does that answer that question?
Yes, ma'am.
Okay.
Yes, ma'am. Thank you. And Natalie says yes, thank you very much. Let's see here. On the first slides, how did she pull the comparison data across STS? How many participants and how they did? So I think you're talking about the Harvest Composite Quality Ratings, Dia. And the Harvest Composite Quality Rating Summary is posted on the IQVIA platform within the library section. So we post one of those with each harvest. So those are out there for you to download and you can share with your institutions. Any other questions? Let's see. Here's a question. Dr. Bauer, did you mention no Foleys in the OR? Any issues with urinary retention post-op?
So, correct, we don't place Foleys. One of our two probably most common post-op events were either urinary retention or air leak. And so to address air leak, we do a lot of stapling of the fissure, try to minimize in-fissure dissection, and then we use Pro-Gel to try and as a sealant to prevent air leaks in the OR. In terms of urinary retention, we have an active trial where we're looking at the prophylactic use of Flomax, but it felt as though when we were placing Foleys that we would create urinary retention because of edema when we took it out. And when we looked at that, our EBL is on average very low, and our OR times are also low, that we didn't need a Foley. So we stopped placing that, and that seemed to make it better. There is some urinary retention, but the benefits of not placing a Foley, I think, are far in favor of placing one. As long, the key there is that if your surgeons are doing, and I know some will do 6 and 9 hour robotic lobectomies, our average time is low. Our intra blood loss is low, therefore our fluid administration is low. So we end up not needing a Foley, and we haven't had an issue by not placing one. We
Thank
place
you.
them for esophagectomies or for other cases that we know are going to have large fluid shifts, but not for the vast majority of our thoracic cases.
Thank you, Dr. Bauer. So Kelly, this is our next question. This is fantastic tracking. I'm a heart transplant, but always appreciate these webinars and love your level of accuracy and reporting. Can you speak to how you started in the creation of your readmission review and tracking dashboard? She's currently working on a similar QI project and would love to do something similar to this.
Time and patience.
Yeah.
So, I mean, it's a manual process, of course. But once you have it running, I copy and use the same one over and over again. So I basically, we're all Google here. And it was just time I manually created it. I created the columns based on what we were tracking, and basically we're tracking everything that's a post-op event in STS and our unplanned readmissions. So I'm not sure if your question is specifically like, how do I do like those drop downs and stuff like that? I taught myself using YouTube.
That's Kelly, that's what I was just going to say to all of the administrators, that Kelly is very resourceful. I will ask her, and I typically don't get very many questions. Then when I ask her how she did it, it was usually Google, YouTube, or a phone call maybe to someone on this group. I would also state that Kelly got her master's in bioinformatics as she was doing a lot of this work. And so that also was to our benefit of utilizing her education.
And she said, to clarify, do you abstract the data from STS or do you manually enter them separately?
So both. So the STS data, we would abstract from a report. So using my vendor, I run a report and look for any post-op events, readmissions. But like I said earlier, we cast our net very wide and look for all complications, all readmissions for all of our thoracic surgery. So I will manually pull it in from another resource, another report, Vizient, or our own internal reporting.
Yeah, these dashboards are, this readmission review tracking dashboard is pretty awesome. So that's some great work.
Yeah, great job, Kelly. This is Carol from the STS. Did you say you built this in Google Sheets?
Yes.
Yeah, it's a Google Sheet. I started using Google Sheets recently, and for making things like these tracking dashboards, it really helps a lot because they have a lot of pre-programmed things in there, formatting that you could do for Google Sheets. So great. I'm glad to see you're using it too.
I'm happy to make a copy of it and delete all my data, and then you can kind of like use it as a template. I don't know if that would be helpful.
Yeah, somebody had asked if you would share your email for any for any questions. I think you just made a lot of friends.
Sure. First I put that in the chat.
The other thing that Kelly has done for us is we created, I don't know how many people use RedCap,
Uh-huh.
but for our M&M process, not just for thoracic, but our whole department, we used to have to send forms into our central quality for the hospital. And what Kelly did, which then ended up changing for the whole hospital, is for our department, she created RedCap, which is, for those that aren't aware, well, Kelly, explain what you did for RedCap and our morbidity, mortality tracking.
So what I did was like, I just created a form in there where it just has some basic information as to what the event was, why we were looking at it, like where the resource came from. And then just some general questions on, was the standard of care followed? What, did we use all our resources to mitigate this adverse event from happening? Were there any areas of opportunity? There's like 5 like basic questions that are asked. And then we added in some other information as looking for, documentation issues. And then so our surgeons do the reviews, they provide their findings, and then I do a final evaluations, and then sometimes find the need that we need to send it to another department to look at. Previous to that, everything was done on a piece of paper. I just took the piece of paper and made it computerized and put it into RedCap.
So that enables me as a chair of surgery or as the chief of thoracic to track by surgeon or resident occurrences, so that if there's a need, it's very easy to go back and say, well, how many of these did we have? Because it's then becomes a searchable database. So there's this is the tip of the iceberg that Kelly has created for us.
Yeah, Judy says that she also uses the RedCap for death complication forms at U of M. Yeah, Catherine says she does the same for all complications through Excel. Any fallouts are discussed with their monthly quality meetings. She abstracts readmission from their EMR and Epic and looks through all the readmit information and provide reports at monthly meetings. So that's awesome.
Yeah, I would say the greatest resource I have is Dr. Bauer, and that he makes himself available. And like you said, back in the day when I started, I came from cardiac surgery. I knew nothing about cancer. And I was like, what, you want me to read these path reports? I was like, oh, a T&M, a what? And I literally I killed a lot of trees printing out path reports and would sit with him and go, okay, so this is this, and this is this, and this is this, and jump 10 years later. And now I'm sending messages to pathologists saying, that staging is wrong.
That's awesome. Yeah. Let's see, a question. I see returns to OR for vascular cases that captured under sequence 3670, if not part of the index procedure.
Oh, I'm not sure what they're talking about.
Yeah, I don't know. Ruth, I don't know if you wanted to. That is
He
something.
returns to OR for vascular case. I'm not sure.
Oh, I think they're looking at my segmentectomy back in 24, it looks like.
Oh,
Had a DVT and went back to the OR for thrombectomy,
Oh, sorry, I had the question box over.
right? I think that's what they're looking at. And I would say you can see right there, yes, return to the OR. And you see how it's highlighted green? That means it's because it's one of the triggers for STS major complication as well. So
oh, right here.
coded
Yeah.
to do that. Yep.
Okay.
I'm assuming that's what that person is looking at.
Yeah. Okay.
It
Yeah.
says- She
Yeah.
said, yeah.
Yeah. Okay. And then Mindy, so Mindy has a question related to, so you can have one participant ID for multiple hospitals. So yes, you can have, one participant ID for multiple hospitals, or you can have, individual participant IDs for each individual hospital. Wendy, if you want to chat offline about that, happy to address any questions about the STS contracts and the way your current contract is set up. But yes, you can have multiple hospitals under one participant ID.
The reason that that Kelly and I set it up that way from the beginning was we were really trying to ensure a high level and the same level of quality across all of our hospitals. And, we also are able to break down and look at how each of us are doing and what is the volume at so we can internally look at how we're doing. But when we've hit 3 stars in the past, that enabled us to say we're 3 stars everywhere. It's harder to hit that when you're working with 5 different hospitals from an OR and nursing standpoint, but we wanted to demonstrate that no matter which of our surgeons, which of our hospitals, we were providing the same level of care.
Carol or Ruth, do you have any questions for Dr. Bauer or Kelly?
I don't have any questions for Dr. Bauer or Kelly. This is Carol from the STS. I just want to say thank you so much for taking time to present your site's data to us and sharing your experiences. And also, Dr. Bauer, it comes along once in a lifetime that we get people like Kelly in our lives who always have your back. And I know that she's a person that you could tell it really respects her job, and she's in the right position to be the support that you need for caring for the patients. It's good to see that.
Yeah.
Good job, Kelly,
Thank you.
in
Yeah.
doing all that. And thank you for sharing with us.
Yeah, it's nice to have that support from your surgeon, because we do hear from data managers that, that's one thing that they don't have is that support from their surgeons like you have. So it's a blessing.
If the person has an administrative assistant or secretary, become that person's best friend. Get on his calendar, her calendar,
Yeah,
whoever's
you're
calendar.
exactly right. When I worked at the surgeon's office, we had a nurse practitioner who did all of the STS data for us, and the surgeons were super busy. But the surgeon, we were the administrative staff. This is before I became a nurse many years ago. But we became best friends with that person, and they were confident that they could come talk to us. And, we were always in the surgeon's ear, calling into the OR for this and that, and, meeting with the surgeons before their day started, after their day ended. And we always had access to our surgeons. So if that person needed us to find out about a patient or check in on something or ask a question about what was dictated in the operative note, we were always there to help. So I think you're absolutely right. Become friends with the administrative staff at the surgeon's office.
And
For
I
sure.
think Kelly is really a central focus in everything I do, either for surgery or thoracic. But I say to everyone on the call, don't ever underestimate your importance or impact, because you can be the agent of change. That as a rule, surgeons are very competitive. They want to always be better. They certainly want to be better than their peers, and they want the best care for their patients. And so what all of you do on this call is enable us to do that. And I think as you demonstrate that to your surgeons, they'll, if they don't, they will very quickly grow to appreciate and respect you for all your work. So thank you to this entire group.
Thank you, Dr. Bauer.
I did put my email address in the chat, but if you can't see it there, it's my first name dot last name, Kelly dot Rubino, Rubino at hmhn.org.
Don't worry, Kelly, they'll find you.
I was gonna say, they'll find you, Kelly. You're gonna
They'll
become
find you.
very popular. Very popular. I think your emails start to blow up. But yes, and if you aren't able to get Kelly's email, just feel free to email me directly and then I can facilitate if needed. So well, I'm not seeing any additional questions come in. Kelly, Dr. Bauer, thank you so very much for your presentations today. Greatly appreciate you all, again, like Carol said, taking the time to come and present to the group. It's so very important, and it's just so nice to have sites and surgeons like you all who are willing to share what you're doing at your institution, so we can, our overall goal, as Carol says, is always to help one another and most importantly, and help it, improve the outcomes of our patients. So thank you. We greatly appreciate it. So
Thank you.
all right. So
Thanks,
with
Dr.
that,
Bauer.
just mark your calendars for our upcoming webinars. Our next 2 monthly webinars are June 11th and July 9th. And then our next quality improvement series webinars are scheduled for the end of June, June 26th, and then the end of July, July 31st. We would love to have additional presenters for our upcoming quality improvement webinars. So if you have a fantastic surgeon, just like Dr. Bauer, that be willing to get on and present with you, or even if unfortunately if your surgeon's not able to join, that's fine as well. We would love to have you join and show what you're doing at your institution to help improve outcomes at your institutions and how you're using your STS data. That would be so greatly appreciative to see. And Catherine says she definitely appreciated having the surgeon on our call. It is very helpful. So again, thank you, Dr. Bauer. We appreciate it. All right. So with that, I don't have any other additional questions. So again, we look forward to seeing you all on our next webinar. Some comments are coming in, and they're saying a great presentation, Kelly, and it was great again to have a surgeon on the call. So we appreciate again you joining us. So with that, I hope you guys have a great rest of your week and have a great weekend ahead. And we will see you on our next on our upcoming webinars. Thank you so much, Kelly. Thanks, Dr. Rubino, or Kelly and Dr. Bauer. We appreciate it. Thank you all very much. I hope you have a great rest of your day.
Bye.
All right. Thank you. Bye-bye.
Bye.